welcome to Emergent Thoracotomy, a review for healthcare providers. I'm your presenter, Peter Forsberg, Physician Assistant in San Antonio, Texas. The objectives of this presentation are to discuss the indications and contraindications for emergent thoracotomy, to review the anatomy of the chest and the cardiorespiratory system, to discuss the techniques for emergent thoracotomy, and to review the complications and aftercare of an emergent thoracotomy. Why, you might ask, do I need to know about emergent thoracotomy? Well, as a healthcare provider, you might at any time be faced with someone who's sustained a penetrating chest trauma. Being somewhat familiar with available interventions might help you facilitate proper care by someone trained in this procedure. And finally, emergent thoracotomy is a phenomenal procedure that demonstrates supreme surgical skill and unbelievable human physical resilience in the face of life-threatening trauma. It's a procedure that's well worth observing. The purposes of emergent thoracotomy are to control hemorrhage, relieve pericardial tamponade, redistribute cardiac output, and provide cardiac massage. The indications for emergent thoracotomy are those patients with vital signs on presentation in the field who have lost vital signs while being transported to a care facility, and victims of penetrating trauma who are in shock or who have a rapidly deteriorating clinical condition and who are not responding to aggressive fluid resuscitation. Contraindications to emergent thoracotomy are patients with penetrating chest trauma with no vital signs in the field, blunt chest trauma with or without vital signs in the field, when after blunt chest trauma, pre-hospital CPR exceeds 10 minutes without a return of spontaneous circulation, when after penetrating chest trauma, pre-hospital CPR exceeds 15 minutes without a return of spontaneous circulation, when after penetrating chest trauma, victims present to the care facility in a systole without a pericardial tamponade, and finally, if a thoracic surgeon or another qualified surgeon is not immediately available to take the patient to the operating room for definitive management. Survival statistics. When vital signs are present in the field, survival rates range generally from 0.6 to 6%, except in those patients in whom penetrating chest trauma is confined to the heart. In these cases, when emergent thoracotomy is performed and competent surgical follow-on is available, survival rates can approach 30%. Please indulge me while I conduct a short anatomy review. The heart, as you recall, is in the anterior mediastinum, the aorta and esophagus in the posterior mediastinum, and the internal mammary arteries course across the posterior aspect of the anterior chest wall, lateral to the sternum. The intercostal vessels course along the inferior aspect of the ribs. The subclavian vessels course across the very superior aspect of the thorax and under the clavicles. The heart itself is covered by a tough pericardial sac. Upon that sac, the phrenic nerves, which appear as white or yellow strands, run from the root to the apex of the heart on either side. Lying on the anterior surface of the heart over the interventricular septum is the left anterior descending artery. Looking into the open chest, you'll observe that the right ventricle occupies the majority of the anterior surface of the heart. The aorta is seen posterior to the esophagus, and finally the vessels coming off of the thoracic aorta are the intercostal vessels which run beneath the ribs. Some of the equipment required to perform an emergent thoracotomy are scalpel handle, scalpel blades, retractors, curved Mayo scissors, 2-0 silk suture on a large curved needle, hemostats, and a needle driver. Some additional equipment are curved Metzenbaum scissors, Satinsky vascular clamp, Finocchietto rib retractors, yank or suction catheter, Giggly saw, and a Lebsche knife and mallet. Patient preparation. The patient must be supine, intubated, and ventilated. The left upper extremity should be abducted 180 degrees and secured. Sandbags or towels should be placed under the left scapula, and the left chest should be cleansed with povidone iodine or chlorhexidine. Drapes should be applied to the chest, and parenteral analgesics and sedatives should be on hand for use as needed if the patient survives the procedure. Sterile technique should be observed as much as possible. Technique. On males, site of incision should be the 4th or 5th intercostal space, corresponding to the intercostal space below the nipple. For females, it should be the 4th or 5th intercostal space, corresponding to the intercostal space below the inframammary fold. The incision should be made with one stroke from the sternum to the posterior axillary line or to the gurney. The incision should be carried through the skin, subcutaneous tissues, and superficial musculature down through most of the intercostal muscles. An army retractor may be used to open and separate the edges of the incision. After the initial incision, mechanical ventilation should be discontinued. Consider advancing the endotracheal tube into the right main stem bronchus. Puncture through the intercostal muscles at the anterior axillary line using the curved Mayo scissors, and carefully extend the puncture to 2 to 3 centimeters using the curved Mayo scissors. Insert the non-dominant index and middle fingers into the incision and separate the lung from the chest wall. Advance the fingers and Mayo scissors simultaneously, superiorly, and then inferiorly to cut the intercostal muscles along the entire inner space. After this, resume mechanical ventilation. Technique continued. Insert the rib spreader with the crank positioned near the gurney. Turn the crank to open the arms of the rib spreader. Look for bleeding. Control bleeding from intercostal muscles with pressure, hemostat, or 2-0 silk. Bleeding from subclavian vessels requires rapid transport to the OR for definitive repair. Opening the pericardium. A pericardotomy should be performed if blood is seen within the pericardial sac, or the heart cannot be visualized through the pericardium, or if there is no obvious injury within the chest and a cardiac injury is suspected. Opening the pericardial sac. The site to be opened is anterior to the phrenic nerve. Grasp and elevate the pericardium with the toothed forceps anterior to the phrenic nerve. Make an incision in the pericardium near the apex of the heart using a curved Mayo scissors. Normally, fluid in the pericardial sac is straw-colored and not bloody. Carefully insert one of the jaws of the Mayo scissors into the pericardial sac and extend the incision parallel to the phrenic nerve from the apex of the heart to the root of the aorta. Deliver the heart from the pericardium and inspect for injuries. Internal cardiac massage may be performed for asystole, bradycardia, or hypotension. If there is a high index of suspicion for injury in the right hemithorax, with minimal or no injury found in the left hemithorax, the thoracotomy should be extended to the right side. If possible, extend the incision through the sternum using a curved Mayo scissor and continue it to the right posterior axillary line. Remove the rib spreader from the left side of the chest and apply it to the right fifth intercostal space. After doing this, examine the right hemithorax for injuries. Note that when the sternum is cut, the internal mammary arteries will be lacerated on both sides. Apply hemostats to both vessels to obtain hemostasis. If unable to cut the sternum with the Mayo scissor, a right-sided thoracotomy similar to that done on the left may be performed. Alternatively, cutting the sternum with a handheld or giggly saw or with a Lebschi knife is an option. To cut the sternum using the giggly saw, pass one end loop of the saw from the left intercostal space, behind the sternum, and out into the right fifth intercostal space. Place an index finger through the loop on each end of the sternal saw and apply pressure from underneath the sternum while pulling the saw upward. To cut the sternum using the Lebschi knife, place the hooked portion of the knife under the sternum with the sharp aspect of the blade against the lateral border of the sternum. Lift up on the handle to lock it against the posterior surface of the sternum and hit the flat knob on the back of the knife with a mallet to drive the knife through the sternum. After performing a successful emergent thoracotomy, immediately transport the patient to the OR for definitive care, continue fluids and blood products, administer broad-spectrum antibiotics, and administer parenteral analgesics and or sedation as indicated. Complications that may be encountered during an emergent thoracotomy include vascular and organ injuries, injuries to rescuers, and infection. This concludes the presentation of emergent thoracotomy, a review for healthcare providers. Thank you for watching and for listening.